Hello and welcome to the EMS Handoff podcast. This is David, along with my co-host Eric McCullough and Bradley Dean. Our Army guys tonight set us up well for success. Ground team, they got to wait for the A-10s to come in and save them, but going to have a little bit of fun tonight on this conversation. We're going to get into some educational topics, but before we do, let's go to Middle Tennessee and see what's up. Eric McCullough.
Nothing on my end other than great weather. I know we always talk about weather like this is how we know we're adults, because every single podcast, it's always like, oh, gee, I know how they're going to lead off the first like 5 to 10 minutes with just talking about the weather because they're like old men. So I completely get it. So I actually don't have a whole lot going on. I know your voice is hoarse because you got to go to a cool football game and you got to see. I do think it's awesome that people are finally getting out and going to places, because all the fall festivals around my area, like Bell Buckle Craft Fair, weird fall festivals on their first year have hundreds and thousands of people just showing up. So that's kind of nice.
Well, the one thing about it is we can say we were running the only football games that made it to every major news outlet this weekend. Not even Alabama and Georgia could sort of really say that. Not necessarily for the good things that occurred, but Eric, we could say, hey, we talked about the weather. I went to Lowe's today to install a new sink and all those adulting things, right? It's that's going to be what this podcast is about. Hey, how to adult in EMS here in the future. But in that case, let's go to the adult on the other end of the spectrum here in North Carolina. Bradley Dean, what's up, my friend?
Oh, great weekend. Got to put my toes in the sand a little bit, so it was great.
Toes in the sand, man. We got, we'll put it this way. Got home from the football game about 2:00 this morning, and it was not toes in the sand weather at that point in time. It was a little cool. We had a nice little cool front came through this weekend. It was nice. So
I was just informed it wasn't sand; it was the litter box.
Oh, well, okay, that's a different thing.
Well, yeah, different sand.
No, we spent a little time on the beach. It was good.
Nice.
Can't complain too much about that. I do have to say, I get a phone call from my daughter today. She's like, hey, by the way, before I guess this is a good time to tell you that I'm in North Carolina right now. So they decided to get up at 4:00 this morning, go over to Max Patch. So she's like, in case you start looking, that's why I'm in North Carolina. So it is kind of strange to think we think about North Carolina being so far away, but from our house, it's actually probably almost closer than one of our main campuses is. That's kind of interesting. So yeah, she was over, I guess, donating to the sales tax collection there in North Carolina to help support you guys. Gotta do that every now and again. So before we get started on today's topic, we want to make sure and give a shout out to our podcast partner, the Journal of Emergency Medical Services. JEMS has been an industry leader in the profession for many years. And while we are your source for all things EMS in the podcast verse, JEMS is your industry leader for EMS news. Make sure and go by their website, jems.com, and find out everything that's going on in the profession, as well as see all of our prior episodes, as well as our fellow podcast hosts. They've got a lot of great people that are out there talking about different things in EMS. So make sure to follow the EMS Today podcast on Apple, Google, and Spotify. And you see all of us in our gear right now. We're going to have to find a way to get our guest today in some EMS handoff gear because the rest of us are wearing our original logos today. Don't forget to go by the Pursuit Company at thepursuitco.com. Love everybody there like showing off. Oh, wait, sorry. I said everybody in their originals. We got Eric McCullough in his keep back line, and then Bradley in the nice gray original. I got our hoodie on. It's a little bit chilly today. So don't forget to go by the Pursuit Co at thepursuitco.com. Find your EMS handoff merchandise. They will get it to you anywhere in the country within short order. So make sure and go by and check them out. So Eric McCullough is going to be introducing our guest today. So go ahead and kick it off, sir.
All right. Well, it's not. I have a guest on, but the topic's going to be Bradley's topic that he brought up. But before we get to the topic, I wanted to first introduce who we have here, which is Greg Johnson. I consider him a close friend, a colleague, and most of all, he's an outstanding resource and an outstanding educator here in the Middle Tennessee area. He is the EMT and AEMT Coordinator over Columbia State Community College's EMT and Advanced EMT program, a highly successful program. Can't say enough good things about the guy. He'll pay me later. But he's a great advocate for EMS education. Any of his students and faculty that work with them, and paramedics have worked with them before, will know this too. So I thought this would be a perfect opportunity to have him come in and speak on our topic, which brings me to Bradley, the topic that you brought us here for.
So somebody posed a question to me, I guess it was a couple of weeks ago, and it's something I've been thinking a lot about and looking at, because today we're dealing with the changes in EMS education that started 5 or so years ago. And we're starting to see kind of the product of that really hitting the streets. So what we see is we see education, we see the didactic, and then toward the very end of the didactic, the way the things are supposed to be set up, when you look at the accreditation of the EMS and everything else, then you go into the clinical or the hospital side of it. And then pretty much when you're done with the didactic, students move into the field. So the question is, how do we provide better context for the things that we teach in the classroom? And would it be better to introduce students to clinical much earlier so they can learn, basically get all their skills and stuff out of the way, and let's turn them into clinicians versus skill junkies?
So I really love this topic, and I think we're, we've kind of bounced back and forth between that 30-minute and hour range. I think we could honestly make this a multi-part, multi-hour episode, because there's a ton of information to unpack as we go here. But the first thing I'm going to do is tell Bradley the way that you do that is not follow that direction that he gave you as far as breaking down this clinical settings. But I'm actually going to pose this question first. I'm going to toss it to Greg. So I'm going to see what his answer to this. This is actually from our last accreditation site visit. And we've actually incorporated this question into a few different places. What is the difference between a clinician and a technician?
I think the biggest thing is that you have a more rounded approach to healthcare. It's not just a cookbook style. This is what the textbook tells me to do, so I have to do this in every situation. But instead, I'm using all the things that I'm finding in my patient's presentation throughout my assessment with that patient to do a better job in treating my patient and during that transport to the hospital.
So I'm going to give credit to Dr. Mai Dorset. That was her question that she liked to pose. And I think it's one of those that's great out there. And it's almost like Greg had some practice with that. We have a lot of people in this profession that question really gets a lot, because the idea behind it is there's a lot to say in the pre-hospital setting. We are the technicians. We go out and find and do what they tell us to do. And then the physicians, stuff like that. But I think the way EMS is changing, and a lot of this we see with ET3 and the treat in place legislation and the field termination for resuscitation guidelines that are coming out, we're really transforming this profession, especially even, a lot of this started occurring pre-COVID, but kind of exacerbated during the COVID situation, that, we are going to primary treatment providers and practitioners. So I'm going to start off, Bradley, and before I kick it back over to you for just a second. This is one where we kind of have to break our levels down just a little bit. For our EMT and advanced EMT programs, are 1 semester in duration. There's some things that are coming about that are shaping those just a little bit, which Greg is involved in as well. And then our paramedic program is 3 semesters. So one of the things, that we do is to start their clinical rotations at all 3 levels as early as humanly possible, because we want them taking those skills directly into the field. And they actually have come back with some questions like, hey, I wasn't exactly sure, this is what I thought, this is what they said, and I wasn't exactly sure. So we were able to take that and dive into the materials just a little bit deeper, and especially our paramedic program, over a year. That last semester, the capstone semester, is supposed to be when they're primarily in the field. We start in the field first semester, coupled with our hospital rotations as well, so that they are incorporating both of those areas, because we want them to know the why behind the what. So, with that, what is the advantage, Bradley, to changing this context in the education setting based on that adage to making them clinicians over technicians?
Well, I think one of the biggest things is what we've got to look at is students often move into clinical and their focus is, I've got to get X number of IVs. I've got to get X number of airway management. I've got to get X number of medication administrations. And the problem is they tend to focus more on the skills and less on the whole patient. And when they're doing that, I believe what we're beginning to do is we're losing the focus of the context. Right now, we've got students that know how to perform psychomotor skills, but the question is do they know when to perform them, or more importantly, sometimes why not to perform them?
So with that, Greg, what Bradley just said, why to perform them, how do you take that question and incorporate that into the classroom in your preparation for the EMTs and advanced EMTs?
It's a great point. And you brought up we started offering this past probably 2 years ago now, a new class. We call it an integrated program where we combine, you mentioned EMT and AEMT being a single semester class apiece. And so we've combined those two classes. Actually, Eric helped build that prior to his departure. And I got to take credit for it. So it's kind of fun. But so we've basically combined those two single semester programs into one. And what that does is it increased the amount of clinical time those students have to go on. But because of that, I can't wait. First of all, it wouldn't be possible for me to wait until the end of all of their lecture and psychomotor content to then send them out to clinical. I have to time. They're in a class so many days a week and so many hours in a day. I can't wait until a certain point in the semester to allow that to happen. So we do, just like you mentioned with your program, David, start our students very early on in that. So, do they have every skill that they need? Have they been taught that in class, every skill that they're going to need to use on that clinical? No. But kind of to what Bradley was talking about, I think the biggest thing we make sure before our students start clinical is that we've gone over that assessment, the process. So your medical assessment and even a little bit of the trauma assessment, they know how to take vital signs. They've done CPR. Everything after that is something that those students are going to see sometimes for the first time on that clinical before we've actually covered that material or covered that skill in class. But they've got that foundational assessment component that helps them start going toward those, I call them radar screens or satellites, to help kind of get to that field determination or field diagnosis or field impression to treat that patient.
Do you see them kind of take the transition from, since y'all do get them in early, do y'all see them start to make the transition from like being a technician where they're following kind of like check sheets, guidelines and stuff, to that clinician, like midway through the semester after they've done a certain number of hours, where you're like, okay, I'm starting to see them develop the clinical acumen even in the semester?
Yeah, I think so. And I think our clinical feedback forms that we get from their preceptors would point to that as well. So early on, obviously, they're very scared. This is a brand new thing to them. But as they go throughout the semester and kind of build on those skills, I think they get more comfortable knowing their own ability and how they're going to be able to get those skills throughout that clinical versus, if you waited till the end, and I send let's say an AEMT student to an emergency room to do a 12-hour shift to get IVs. I do believe that they would be so focused on just chopping patients down the line to get IVs versus actually worried about, seeing the content in the clinical and getting the most out of that clinical.
Well, you made some really good points in there, Greg. And one of the things, on the paramedic side, this is when I'm talking to them about their clinical rotations, it's kind of the way I mentioned it to them. I said, look, your first semester is primarily taking the skills that we teach you in the classroom and putting them to use. The second semester is continuing that process and trying to get as much access to as many of the skills in the field as possible. But you're starting to learn that process of being the paramedic. And then on the third semester, you are that paramedic. And so it's actually putting that gauge and saying, you're here, and then it's you, is kind of changing. And we're bringing that mentality in the EMT and advanced EMT side, saying, hey, when you go out, your first steps are to just take this information and put it to use. Figure out how that traction splint feels, or that a SAM splint, or an oxygen non-rebreather mask, or something, and just figure out how to communicate to the patient what you're doing. And then by the time you get done, even as an EMT, you should be thinking like the paramedic on the back of that truck. You should be able, because if you're on the fireside rescue, or even on a BLS service doing interfacility transfers, you may be the person. And so you can't think of this just as a skill. You have to think of this in your interview and such stuff like that. And so part of that conversation does lend outside of the classroom as well, in setting up both the lecture and the didactic, the lecture and didactic, the didactic and psychomotor, in such a way that it's no longer, we're going to do you're there for a blind airway insertion device, or you're there for an intubation. Everybody comes into paramedic going, I want to learn how to intubate. We can teach anybody how to intubate. It doesn't take very long. Hey, do this, lift here, insert tube, you're done. But what we are there to do is manage the airway. Is the endotracheal intubation, or is that blind airway insertion device the end all be all what you need to manage this? And the answer is possibly not. In fact, it could possibly hurt if you don't pre-medicate, or some other stuff, right?
I think that's the importance there. It's just like you said, it's not so much teaching the actual skill, but trying to have the technician become a clinician to figure out, when do I apply that skill? Do I need to intubate this patient, or would a supraglottic airway, would a King airway be the appropriate airway choice here? And so I agree. And kind of going back to what you said earlier, we're doing the same thing on the EMT and AMT side. So I brought in from the paramedic side, where in that last semester, they get the team leads. They are the paramedic. It's their call. They're running the show. So I bring that in now. In the last 2 to 3 clinicals that our students run, they have to, or they're supposed to be the team lead. So they're supposed to run that call as the ALS provider on that truck. Now, obviously, if the skills that the patient needs are at a higher level, the paramedic has to step in and perform that. But I expect the student by that last 2 to 3 clinicals to be running that call, because they may not be staying in Tennessee. These providers that we're educating here may be going to neighboring states where they are going to be the supreme leader on that truck for that shift. And it's going to be their call. And so I want to see that progression that you're not going to see if we just said, okay, here's the didactic portion of what you're learning. Here's all your skills. Now go forth, and you've got to have 50 IVs in the next 4 weeks.
Yeah. And I'm sorry. Go ahead, Bradley.
No, I was just going to say, I was going to run that rabbit hole for just a minute, because you brought up endotracheal intubation and other things. How many times do we have students to, drop the ET tube, or put in that blind insertion airway device into a mannequin that's on the table, and then they pull it out and the next person comes by and puts it in? When we teach people, hey, you need to reconfirm the airway after each move, the problem is how many times do we actually let the student secure the airway, move the patient in the classroom to reinforce what we're teaching, versus, just put it in, all right, take it out, next person steps in? Because in the field, if I intubate a patient and it's a successful resuscitation, or if it's a trauma, I'm going to move that patient a minimum of 4 to 5 times before I turn it over to that care.
So that's, as far as kind of what we do, I think that gets into a lot of our simulation training as well. And the fact that, we use a product, and I don't know about giving shout outs or endorsements on this podcast, but we use the iSimulate products. And so we build those scenarios into our simulations when we run those frequently with our students. So as we say, okay, we're here, we've resuscitated this patient. Now we're going to move them. We've got an ambulance box simulator in the classroom that we now load that patient on a stretcher and into that box. And Now, as soon as we get that patient load in the ambulance, I can change a scene to where they start to desat. And the students have to think, okay, did my supraglottic airway, is something wrong with it? Or do I now have, do I need to consider that dope mnemonic when we're dealing with paramedics and talking about intubation? So we try to mimic what you're talking about there as much as we can with the available tools we have simulation wise, so that hopefully, again, kind of going from that technician to clinician level, students can recognize, they can see that and recognize that, and hopefully differentiate and treat that the proper way.
So I'm going to kick over to Eric in just a second, because I know he had a comment a second ago, but I do have one question for you, Greg. How often do you toss a patient into your scenarios that are basically otherwise healthy and just dial 911?
That's a great question. We have Chad Hollingsworth, who teaches on our paramedic side, and he's famous for his avocado pit poisoning scenarios. So it all depends, but I'd say probably not enough, honestly.
Well, and so the reason why I asked that is it's kind of funny. One of our instructors that retired a couple of years ago, would love to still have him about, but it was basically known that, when I went through his program many, many moons ago, first and second semester, there was not a patient that survived. They were going to die. You could do everything absolutely perfect. They would come back to life. And for some reason, 5 minutes later, they'd be dead again. And sometimes in the third semester, you would have an opportunity to save somebody, but chances are not really. And it's one of those things that now, we spend so much time that they go to some of their testing scenarios and they're like, they fail because they're expecting the person to die. So they get a little bit proactive and they have to do something. And so one of the things that I found is, let's just toss somebody in there that's really otherwise healthy, just dial 911 because they needed to go to the hospital. And so they get in, they're like, oh, I've got to do this and this and this. We need RSI and intubate and, all this other stuff. And it's like, why? So I just thought that question was kind of interesting. We'll come back around to that. But Eric, you had something a second ago.
Yeah, no, I was, since we were talking about context, I think that was the hardest thing as an educator, was to try to bring in some context, because as much as we like to think that the book world reflects the real world, and when we say that, we kind of say it kind of pithy, where we just kind of like, that's what you do in the book world, but not in the real world. We're not realizing that, no, actually the book world, the studies that we see should reflect those standards. And actually, I was going to get into that whole simulation thing, that do you think that driving simulations earlier on is helpful and engaging? Because I think it does. I can just tell you from experience from teaching that when it came to simulations, you got to see the gears going. Like, you got to see how the amygdala impacted their higher order thinking skills. I will tell you, I'm guilty of never giving very not sick patients, which is, as a paramedic that's working on the side at a pediatric clinic, realizing that 95% of my kids are fine. They're not sick. They're coming to an urgent care. They got sniffles. They need lollipops and stickers. And I realize that. And what's funny is, over the years, I've catastrophized everything because I've been an instructor. And I've created scenarios where I have created all these catastrophes, like he was saying, the avocado pit poisoning. So we both know Chad and talk to Chad all the time. I should have him on here as soon as he's done nursing school. But what do you guys think about integrating simulations? Like, if an instructor is listening to this, or a wannabe instructor is listening to this, like, how soon do you start integrating those simulations so that you can start getting some context to your training?
Well, I'm going to, that actually that question drove perfectly to the next part, and I'll kick it to Greg right after. But, this is one of those things that if we were to basically tie this to basic human development, we're talking about crawl, walk, run, right? Obviously, the first time that you have somebody put somebody in a traction splint, you don't want it to be in this mass casualty where there's 18 people laid out on the ground, and you've got this command set up, and everybody crying and yelling and screaming, and helicopter sounds and sirens and all that going. You have to have an opportunity to develop some of the base, or the skill memorization, muscle memorization for some of these different skills. It's the way it is. And then you incorporate it into, small 1 or 2 person scenario, and then you can incorporate it into a larger where they have to then pick. It's, that scenario, your intermediate scenarios, one where they know they're going to be doing a traction splint. And then the last one is, here's your ambulance and your equipment, and here's your patient. You figure it out. Right. So with that in mind, I'm going to tie that to my question for Greg is, are we preparing our next generation EMS instructors in this thought process, knowing that they come from a point in time that at one point they're sick, they get 15 liters of oxygen via non-rebreather, and automatically get put on the monitor and get an IV? Are we preparing that next gen for that inclusion of this clinician type mentality?
Honestly, to answer that, I'd say probably not. And I'd say that's a twofold. And I can go down another rabbit hole on retention and pass rates for National Registry. But as far as preparing students in the simulation world, I don't think we are. I think we a lot of times are worried about so many other components of education that we don't focus enough just on that skills part of making sure the students truly get from that technician and clinician level, because we don't have the time to spend on it. We get bogged down, like I was saying earlier, we get bogged down with pass rates and retention and wanting the students to be successful in National Registry. And so how much time do we put over in that bucket, and how much is left then to truly worry about the psychomotor component? And what you were saying earlier makes perfect sense. I'll use American Heart, for example. When we first, day 2 of class, we're teaching our students CPR and going through American Heart BLS. And so when you first start that class, right, it's here's how to compress and here's where to compress and here's what it looks like, go do it. And then at the end of the class, okay, here's your testing, here's your scenario. You've got this, the patient's going to go into cardiac arrest and you're going to have to do CPR. And so that's great. But then taking that, you talked about crawl, walk, run, taking that a step further. And now, here's your bag, here's your stretcher, and here's where you're going to on campus. And like you said, you don't know what you're going to see. Having to manage that patient in that simulation setting changes things. But I don't think as educators, I think it's something we certainly need to improve on and make sure that we understand the importance of the psychomotor side as well as purely passing National Registry for a pass rate perspective.
So, we spend obviously a lot of time here, and we're not going to get into too much of the other healthcare professions. But, one of the things I find interesting is I talk to individuals that are going through medical school, nursing school, PA, even the graduate nursing programs and such. It's kind of interesting because I think EMS really is on the cusp of the development when it comes to some of these scenarios and simulation developments, and putting people in those critical thinking opportunities earlier than even the physician programs that are out there, which I think is pretty cool, that we can be the ones that are on the forefront of that.
Does it matter though? I guess kind of to kick that back to you, does it matter that, you mentioned earlier, our programs are a semester in length, right? So I'm taking an EMT basic student who's had no medical background, no knowledge at all. I don't know about your case, but in my case, they don't even have to have had college level anatomy and physiology. So they come in and they've got to go in 15 weeks, 2 to 3 days a week. They've got to go from know nothing to baby doctor, practicing almost as at a doctoral level, making those types of critical decisions in a 15-week period, two day a week deal. So I love the discussion because, you're talking about how we've got to be better. We've got to do better to get those students in the short amount of time that we have them to be the best that they can be.
So great segue. It's almost like we were thinking on the same level there, because you went directly to where I went to next, because most of the time when you walk into the classrooms, and this isn't saying a Greg classroom or Eric, myself, or Eric, Bradley, is the commercial off-the-shelf textbook, EMT, Advanced EMT textbook with the PowerPoints that come along with it, the test bank. We're one of the only professions that I know of that kind of compacts everything into one source, and have the mentality that that's it. And this I guess this really is a challenge, but and I see what Greg may be doing as well. But it's kind of interesting. There are a ton of different resources that are out there. Just last week we were talking about Foam Pratt, and they have resources from EMT, Advanced EMT, and paramedic levels, even critical care. There are plenty of podcasts. We got Flight Bridge and EM Crit, and we could Medic Mindset with Ginger. There's so much stuff that's out there, but we can also pull from those medical textbooks and nursing textbooks and pharmacology, even at the EMT level. So Eric, Greg, what kind of additional resources have you all started using?
Yeah, it's a great question, and I think that part of it is like I said, we've only got such a short window to teach these students. So when it comes to using those book provided PowerPoints, it's the easiest, simplest way to go about, trying to cram that information in. But I am a huge proponent of not using the book PowerPoints. And I've often threatened my cadre, if I could find a way to pull all those back and never let one of my instructors use those, and make it illegal somehow, punishable by the death sentence or something like that, that I would probably go down that route, because I just hate those things. And I know I've had offline conversations with Eric before about, rewriting the textbook or not even using a textbook at all. Instead saying, let's use National Association of EMTs, let's use EPC, and let's use TECC and PHCLS. And you've got your American Heart BLS, manual and PAIRS manual, and these sorts of things. Instead of having one textbook, use all the different publications that are out there to teach this content to our students, instead of one textbook that just gets handed to them on day one.
Well,
and I just want to say, because that to me provides greater context for education, because like you were saying, you can't go to medical school. Me and David talked about this before too. You can't go to medical school and figure out what medical books you need for school. It's well, it depends on the professor. We've talked offline, me and Greg have before, about just doing away with the textbooks, because the idea is, if the answer isn't in the textbooks, then any questions that you ask is completely null and void. And that's bad, because really good test banks don't go off of a textbook, because the National Registry sure as crap does it. The only thing I know that the registry for sure references is AHA standards when it comes to that, but that's it. There's really nothing else they really reference. I like the idea. I mean, you're right. It is convenient. The PowerPoints are convenient. The textbook is convenient too. It's one single source. All you have to do is buy that one thing. Everything's right there. The problem is, it's not often updated. Some of them are not that well written. Some of them are way too technical. And we have learning support students that come into these courses that are not reading at the 10th or 11th grade reading level. They're barely reading at the 8th grade reading level. I'm not saying the AMLS or PHTLS textbooks any better, but at least that is a resource they could use later on. So yeah, having industry acceptable textbooks and references gets them used to, hey, this is the acronyms in our world. This is what we reference. This is what we use.
Well, you guys brought up podcasts. That's something that we point our students toward. I know he used to be a medical director in Ohio, where I'm from, but Dr. Pickett is down in Austin, Travis County in Texas, and he does a podcast. And a couple of weeks ago, I had the students do it a couple of weeks ago, but probably 2 years ago now, he recorded a podcast on gas laws. And so when we were talking about that particular topic, I had my students go and listen to that podcast, and they had to do a little discussion post about it. So I got them out of reading, black and white words on a page, and finding some other medium for them to get that content.
Well, this is, there's a tremendous amount of conversation nationally about the flipped classroom. And, we have a lot of resources that are available to us. And so, what is it about, being in the classroom and taking a quiz, or, being in front, what is it about, assigning homework, like you said, hey, do a discussion board post on this topic. About a year ago, I finished Squadron Officer College for the Air Force. there wasn't a single textbook. We had about 20 classes that were required to complete the program, and each one of them, basically had a asynchronous lecture content that went with it. And then, once it got to a leadership theory or there was either a journal article that had been written on it or a study that had been a case study that had been done about an individual. And this is where we could take and let loose some of these students to say, okay, you've got a week to read over, this area, do some study on it, find some resources and put a paper together.
Yeah. Can I just be open-hearted for a second about this? Because this is where it really bothers me as an educator. And David, I think you'll agree with what I'm about to say. At least in our realm of things, we have to take students, at least on the EMT and AMT side. I don't have interviews. I don't have anything that, I hate to use the word weed students out, but basically students come in and they want to be an EMT or AMT. We accept them. They pay their money to be in the program. And as long as they pass the background check and pay tuition, they get to come in the program. And they come in and they don't want to study. They don't want to do what's required, to get through this. So going back to using the book and using those PowerPoints, I think we've kind of felt like we have to get everybody on that equal playing field, because when you bring up flipped classrooms, I can't get students right now to take notes in class and go home and study them, much less be responsible enough to go read through that chapter or go read that resource to come back in. It's certainly frustrating. We're seeing more and more, and it's different causes. I think, Tennessee Promise, for example, here in Tennessee is a great thing that provides tuition-free learning for our students when they come straight out of high school. I think it's a great thing, but it also is one of those where we see a lot of parents say, yeah, you either have to go to college or you have to get a job, and students are choosing to come to college and they have no idea what they're getting into. And kind of going back, I don't want to stop there, but kind of going back to the first question that Bradley even brought up, part of the other reason, not just in time, but part of the other reason I make our students do clinical right away is because I want them to be exposed right away to those situations where they are in a 4x8 box or however big it is. I don't know, with a patient, a real live patient that's got a real live problem where their life is hanging in the balance there, and right away say, okay, I either like doing this. This is something I enjoy doing and I'm going to put my passion into, or I'm not going to do it. I don't like this. This is not for me. And I have tons of students that will come, they'll register in the program, they'll do everything. And then they go to that first clinical and they call me after it's over and say, Instructor Johnson, I'm done. I'm out.
And we've actually seen that here recently. And it's kind of interesting is this semester itself, I actually received an email from one of our instructors who goes, the individual that I thought was probably going to be our most or our best candidate to complete the program just sent me a message and said he went on his first clinical rotation and realized he really wasn't up for this. But I'd much rather see that individual kind of come to that realization and let's find, him the spot that he wants to be, because if that's the case, then he may get out and work 3 to 4 months, if that, and then leave as well. And, our goal is to get those individuals out in the field that are there looking for a career and trying to make this industry even better. So, and
that student going back to the flipped classroom, that student that you're mentioning there is not going to put in the extra time. They're not going to be as concerned about finding those resources and doing that flipped classroom content because they're not passionate about this. It's not something they enjoy doing. So even if they do make it through your program and get out and they work that 4 months you're talking about, what kind of provider, what kind of clinician have we set loose there?
So I'm going to kind of point directly to you guys because I know the way that you all have your instruction set up as the academy style and kind of push for that as well. And this is kind of interesting. It's, as we talk about education, EMS education and specific and looking to that public safety, public health type realm, a lot of times we've kind of gone into those paramilitaristic environments and, kind of using that discipline. But what I wonder is are we kind of at precipice? Are we at a crux in which we have to say we have to kind of change the way that we educate now? And instead of just saying, hey, you will know, this is a PowerPoint, this is the book, you go do, to saying, hey, we need to find what motivates you to learn and inspires you to learn and empowers or impassions you to learn, right?
Yeah, we had a Dr. Cawthon, my boss at the college, at the EMS Academy. We have conversations about this quite frequently because we do have that paramilitary style academy approach, and we've softened up. I think Eric was the bad guy, and once he left, we all started kind of just being. Now we're just big teddy bears.
Yeah, I got it. Yeah, that's it. Yeah, that happened.
Yeah, so we have these conversations quite frequently, and we had a lady from, I believe she was from Vanderbilt, that came and spoke at a convocation a couple of years ago, and she was talking about the Gen Zers, and she kept making this point: you have to meet them where they are. And I remember Dr. Cawthon and I turned at each other while she was talking and said, no, we don't. Absolutely not. They're going to meet us where we are. And we drew a line in the sand and put our foot down and said, absolutely not. But, it seemed like literally the next week when classes started and we got that next group of students in, my jaw hit the floor and I went, oh my gosh, I'm seeing everything that this woman just talked to us about. I'm seeing in the classroom. And that paramilitary style approach didn't necessarily work with those students. I had to find a different way to help motivate them and figure out what worked for those students. So it's a great point you brought up.
Now, I do want to kind of preface this, and I shouldn't say preface. I want to add to that because I think because of the way that we do operate the chain of command structure, many places have, the line EMTs, AEMTs, paramedics that are out there, then your supervisors and deputy chiefs, directors, whatever they're called, this isn't we soften because we are in a tough environment. We need to prepare individuals to be ready for pretty much anything. I know during my field career, I was the one that found myself in places that you wouldn't really expect. A small single wing airplane stuck 50 foot up in the tree with two people in it at 10:45 at night, and fire. So you do have to prepare those individuals, but you also have to find a way, because just by telling them you will go do may not go do. So it's a balance, and it's almost a slack line balance to say, I may be falling over one way or the other, but you keep that structure and that discipline while also, for lack of a better term, tugging on those heartstrings.
Yeah, I agree. We use the word grace a lot. So figuring out, where's the right line of toughness and grit versus also understand grace and allowing people to kind of build up and get to where they need to be, and understanding where they have to be in this profession. I tell my students, my thing is respect. You've got to learn, you talked about, knowing sergeants and captains and lieutenants and all these things. My thing is respect. You've got to know right away that the EMS, we operate a little differently. We have a thing called chain of command. All those components come in. So my students have to learn that, whether they like that or not. That is something that we are not going to move on. It's not something that we can get soft on. The students have to learn that about our profession. But when it comes to teaching the psychomotor skills or expecting them to be, an A+ student right off the bat, part of that, I think we can move on a little bit and give those students a little grace and help educate them how to do what they're doing better, how to learn better. I know in my role, it's not just about teaching them about medicine. It's about teaching them how to learn about medicine and understand medicine. And I think that comes into play there too.
So we've had quite a bit, and it sounds like we've kind of, I'm going to say this, it sounds like we've gotten off the topic of developing the context of that clinician of the provider, but I really think, everything is kind of sitting in that realm that, the deeper as our full-time adjunct faculty are in, not just in initial education, but really in any of our realms, whether it's, those that are teaching research, CPR classes and ACLS and PALS and TCCC or TECC and all those classes, it's kind of changing that mentality to, it's not just another class you're coming to. We're going to create and inspire and do a new class so that we can get deeper and better understanding providers that are out there. So the more we know, the more we care, the more we pass on to our students, the more when they go on and they turn around and precept, they are also building that. Because really, I think this is all, so I'm going to use this as an example. There's 4 of us that are on here. Greg's our instructor, and he's out there, bringing all this and, hey, we need to do this. But Eric and Bradley, they're the 2 out there on the road, and I'm the student. If I go out there and Eric and Bradley basically tear down everything that Greg is doing, I'm influenced like, hey, you don't really need to listen to him, because you just put this oxygen on them, stick this needle and put them on the monitor. We'll get them to the hospital and they'll do everything else there. So, it's all of us that are involved through all the levels to build that next generation student to come out better than even we were now. So, all right, I'm going to go around the table here and kind of wrap up this evening and kind of take this context in EMS education to create that clinician over the technician, and just give us your final thoughts, any kind of shout outs that you might have. And we'll go ahead and start with Greg, our guest, and get his final thoughts for tonight.
I think the biggest thing first is knowing your team as an educator. You're not doing this on your own. You've got a team around you, and you just brought up having your preceptors tearing down what you're trying to build up in the classroom. And I think it's important that first you start and make sure that your cadre is supporting, and we're all singing off the same sheet of music. And I'm very fortunate where I'm at. You talk about giving shout outs. I couldn't have any better of a team than I have at Columbia State with my cadre and with Dr. Cawthon. So I think that's first and foremost is you've got to be strong. Your team's got to be strong. And then you've got to set a tone with your preceptors, the folks who your students are going to be riding with. They have to know that there's a level of expectation. I think that sets them up for success. I think it teaches them or lets them know that this is where you're intended on taking this profession. So if they're not there yet, that this is where you're training future providers, future clinicians to get to. So you start there, and then I think it goes right back to the classroom and making sure that you're getting this across to your students and making them understand how important it is that, I use the term cookbook medic, that you're not a cookbook paramedic, you're not a cookbook EMT, that you know how to think outside the scope of just doing what the protocol says, because sometimes there are situations that will pop up where that protocol doesn't necessarily 100% apply to that patient. And you have to think critically to do what's best for your patient.
I think the one thing you have to think about is how can you be a cookbook EMT or cookbook advanced or cookbook paramedic when you're not going to have a cookbook patient that is sitting out there. They don't follow the recipe. Somebody present like a creme brulee, and really they're just an Oikos Greek yogurt. You never really know. So Eric, what are your final thoughts for tonight?
Yeah, pretty much just echoing what we've been talking about the whole time, which is the sooner you can get students into seeing patients in real life, so that when in the middle of the semester, when you are going over asthma or diabetic, you have at least 6 students in there who have seen these patients, who have treated them, who've been around them, so they can provide so it hopefully will make more sense to them. Simulations is another way to create good context, but it means good simulations. If you build really terrible simulations that are really shallow with not a lot of development and time in it, the students are going to see right through it as a checkbox thing. It's not going to create the context. All it's going to do is create just a fun activity somewhat that they kind of have to muddle through. So be thoughtful about how you want to engage and create the context.
No surface level simulations. I actually like that. That's really good. We've had some really good ones and you watch the light switch on page the students, and it's great to see. So Bradley, you had the topic generation for tonight. So go ahead and finish this up with your final thoughts.
So one thing I would say is we've got to make sure that we connect theory with actual real world application. Contextual learning is not something that's new. American psychologist and John Dewey once said, education is not preparation for life. Education is life itself. So basically what he was promoting is, we're all lifelong learners. Each student comes with their own set of previous context, their previous thoughts, their gaps. What we have to do in the classroom and the lab and the clinical setting is we have to take all of that and meet the students where they are, but at the same time, bring them to the next level. And we can do that by providing that context as we're going through different theory in the classroom.
Well, and I absolutely think that, we have honestly just scratched the surface tonight. So I'm going to venture to say we're going to call this part 1, and we'll bring Greg back, and we may have to toss Chad on here with him and see just how many rabbit holes we can go down on that day. Nothing better than seeing Chad walking around in his sandals. Got to give him some credit for that. So
I love the Birkenstocks.
Gotta love the Birks. So we'll have, we'll bring you back to discuss. But I do want to thank you, Greg, from Eric and Bradley, myself. Thank you for coming on tonight to talk about this. Hopefully some of our educators have taken on some new thoughts about this topic because of this episode. But even if you're a student that's out there, think about it. If you're interested in education, develop yourself even just a little bit more. Go in depth. If you don't know the topic on something or title on something, pull that thread, learn a little bit more. You're going to do nothing but provide better patient care for either the ones you see, or if you start to educate somebody else in the future, you will help them get a little bit deeper in the treatment of our patients as we start to be a definitive care aspect from, again, those treat in place legislations, ET3, those kind of things, where we are treating and even releasing. There's a lot: mobile integrated healthcare, community paramedicine. There's many different terms. So, Greg, thank you for coming on this evening. As we wrap up tonight, we like to let everybody know, make sure to go by all of our spots. So Eric is keeping our website rolling at emshandoff.com. Make sure you go by there. If you like our video episodes, make sure to go by youtube.com and check out the EMS Handoff. Make sure to subscribe so you can get every episode as we release on Wednesday at noon. If you're listening to this on audio, we love to support Jim, so make sure and go by and see them at gyms.com. But you can also come by to YouTube and subscribe there as well. And we always like to hear from you, and our Facebook group is one of our most active places. Come by, send a message, see some of the things that are going on in the profession with our next handoff coming. You'll find all of our information there at Facebook on our group, the EMS Handoff. And don't forget to go by, whether it's the Key Back podcast line that Eric's wearing, the short sleeve shirt that Bradley's got on, or the hoodie you see me in, go by the Pursuit Company at thepursuitco.com. Check out your EMS Handoff merchandise. Until next week, this is David, and on behalf of my co-host Eric McCullough and Bradley Dean, take care, stay safe, and always remember the value of your EMS Handoff.